Today's POPMA Study Club multidisciplinary series is From Scalpel to Slide, aligning surgical oncologist needs with oral pathology expertise. On behalf of POPMA, that is the Practicing Oral Pathologists and Microbiologists Association, I, Dr. Bhuvan Nagpal, extend a warm and heartfelt welcome to all the participants joining us for this month's multidisciplinary edition of the POPMA Study Club, organized in collaboration with CQME and Sapra Multispeciality Hospital, Hisar. Today's session, which is titled From Scalpel to Slide, Aligning Surgical Oncologist Needs with Oral Pathology Expertise, is more than just a discussion. It's a powerful reflection of how interdisciplinary collaboration can enhance patient outcomes, especially in the complex domain of oral pathology and oral oncology. We are truly honored to welcome our distinguished guest speaker, Dr. Deepak Nayan sir. He is senior surgical oncologist at SMS Hospital, Hisar. Dr. Nayan's extensive clinical experience and commitment to comprehensive cancer care makes him the ideal expert to guide us in understanding how surgical and pathological domains can work hand in hand. So let us use this opportunity to engage meaningfully, ask insightful questions, and strengthen the bridge between clinical intervention and diagnostic excellence. I also invite our esteemed moderator, Dr. Nidhi Jadhav ma'am, to formally begin the session after my introduction, and she will be taking the questions. So, Dr. Deepak Nayan sir is a senior consultant in the Department of Oncology and General Surgery, and he has over a decade of post master's experience. He has done a doctorate of a national board in the surgical oncology, and his areas of expertise include head and neck cancers, thoracic and gynecological malignancies, thyroid surgeries, commando surgeries, breast cancers, and sarcomas. And he's highly skilled in robotic, laparoscopic, and open surgical techniques, having undergone advanced training in robotic surgery. In commendable initiative, his department offers free microvascular flaps in collaboration with plastic surgeons, ensuring not only survival but also aesthetic and psychological rehabilitation for cancer patients. We look forward to learning from his vast clinical insight and collaborative vision as we explore our surgical precision and pathological clarity must align for optimal oncology care. So over to you, Dr. Deepak Nayan sir. Uh,
Good afternoon, everyone. Am I audible?
yeah, you are audible, sir. You can put on your cameras also, sir. Yes, you're audible. Yeah. I request
Uh,
everyone to post their
sure,
questions in
sure.
the chat box, and here we go.
So my
Sir, you can enlarge the screen, sir. The slideshow view.
yeah, I'll start
Sir,
the slide.
beneath that slideshow view is there, sir.
Yes, yes,
Yeah,
yes,
next to that. No, next to that, sir.
yes.
Yes.
This one.
Yeah, even next to that full screen, sir. That will keep on playing. This one, sir. No, no,
This
no,
one. This one.
sir. Down. Yeah, next to that, sir. Yes, this one. Yeah.
This one.
Okay, sir. Over to you.
Okay. I absolutely thank you. Thanks a lot, Dr. Bhuvan. You have this topic which you gave to me actually is more towards oral pathologists rather than surgeons. Surgeons are meant to make mistakes, which pathologists, like good pathologists like you, they have to take it on themselves and correct it. But it was so humble of you to choose me to, so I can do justice with it. So I have tried my level best what I can do it with it. So starting with it, what are the needs which one need to align in this? There are three things in histopath report which one need to worry about. First is margins, second is staging, and third is prognostic factors. So what is staging? Staging is T and NM. So, and metastatic workup, we cannot do anything about metastatic workup. It is all clinical in nature. So, we won't be talking about it. Staging T and M, T and N in tumor and nodal staging. So, latest AGCC staging has come regarding it. And if you see seventh AGCC staging, in that there was no depth of invasion in head and neck cancers. Now there is depth of invasion, and when you talk about depth of invasion, there is very absolutely important point regarding pathologist is that you have to take depth of invasion from the submucosal margins. For so, what is difference between tumor thickness and depth of invasion is if a patient has exophytic growth, then his tumor thickness will be much more than the depth of invasion. So, in a takeaway point is whenever we are taking the biopsy, we have to take the biopsy from the edge of the patient, edge of the tumor. If we are taking biopsy from middle of the tumor, we are not only we are going to take the necrotic part of the tumor, also there will be no submucosal membrane to distinguish because you might be taking the exophytic part of the tumor and then you will be blaming oncopathologist for reporting that kindly submit the corner of the tissue. So they which there will then there will be hassles with the patient. Okay. Second thing is if the tumor is ulcerative in nature, if tumor is ulcerative in nature, what will happen? The tumor thickness will be much less than the depth of invasion. So these two things are very important to note regarding it. And regarding margins, there's so much to things to know about margins that we have to start from it. First of all, and why margins are so important? Because it is the most important factor during a surgery. It is the most controllable factor. You can change everything around a surgery by changing the margin. Margin will decide your approach to the surgery. Margins will decide you how much defect you are going to create, and it is the most controllable factor. If the margins of a your sort of margins are wrong, you can actually make patient come early with the disease. So there is increase in mortality and recurrence in all oral cancer sites by 90%. So that is 90% is almost double you will get double recurrence in your OPD if you are not taking care of the margin. For prerequisite for having a good margin assessment is the specimen should be intact. This is the hand of the surgeons. Surgeons should make sure that they have sent the intact specimen. They should not indulge in the urge of cutting through the tumor. If you cut through the tumor, then you will be in trouble. And avoid the fragmentation of tumor. Use first of how do you will go ahead with the margin assessment is first of all surgeon should make sure that he has put nice sutures explaining which side is what. Pathologist cannot tell just by seeing the tissue that is okay. One can understand if it is a very big, like for example, it is bite resection, then one can make it out okay that is maxilla, that is mandible. But in case of small tissue biopsies, in case of skin tumors, you won't be ever be able to tell which side is what if that side is not oriented. So one has to put nice sutures around it to tell the sides of the specimen. Along with it, clinical data has to be put. What type of specimen it? Is there any flap around it? Is there any recurrence around it? Whether there is a previous treatment of any treatment patient has taken. Sometime patient has undergone radiotherapy, chemotherapy. All those oncopathologist is not going to get any kind of history from the slide. So these are all the things which surgeon should do. Is it a recurrence or is it a primary tumor? It is very important because all the kind of uh, uh, possibilities around a diagnosis change around it, whether there is any associated flap which surgeon has done, or this tumor has coming from new flap around it. So all these things we should be able to, information should be given to the oncopathologist. Now, margin assessment is of three types: mucosal margin, deep margin, and bone margin. So, mucosal margin uh, are done differently than the bone margin. How they are done differently? The sections which you take from for the mucosal margin or deep tissue margin is radial. So, what is a radial margin? Radial margin is like the way you cut a cake. So when we take the slice of a cake, we can it is taken radially. And what is a shave margin? Shave margin is how you shave a orange, how you peel off the slices of an orange. That is a shave margin. So mucosal margin are radial margins. We have to always take so that we can know the uh, distance from the edge of the tumor to the edge of the cautery or edge of the dissection. So that distance can only be taken if you have taken it radially. Deep soft tissue like this is the bread loafing. Bread loafing is done in this case to exactly know how you are going to take the. For example, this tumor is ending there, and you have taken slices ahead. Which so what we do, it is impossible to take whole the specimen. In small specimen one can do, but for big specimen it is impossible. So what they do is they are going to take the grossly whichever is the edge which is the closest to the tumor. They are going to take that edge and they are going to see how much it is away grossly. So grossing of the specimen actually is should be done, ideally should be done along with the surgeon. And why it is that? So that surgeon can tell you exactly the correct anatomy and pathologist can then put the specimen immediately after the surgery. Ideally, grossing should be done there and then, but it is not possible in our scenario. What we do is we put specimen in the formalin, and then what formalin is going to do, formalin is going to do contraction of that specimen, and that contraction is around by the uh, 10% immediately. In fact, it depends upon the type of specimen. If, for example, tongue specimen is there, it will contract by up to 40%. So 30% is what, on an average, we decide that up to 30% of the specimen is get shortened by use of fixation and all those techniques before it is put on the. So if you are going to do crossing after all those stuff, so we are going to grossly do a wrong grossing, but to accommodate that, what we do is we take margins accordingly. And for example, if we have to take a margin of 5 mm microscopically, surgeons what they do is they try to take margin 1 centimeter so that on the slide, on the microscopic workup, it doesn't look to be a specimen which is close in, which has closed margin. So now this is left hemicolosectomy margin. In left hemicolosectomy, the suture which you have seen here, it is the orientation suture. This is orientation suture. It is telling you it is anterior. Now, once you orient it anteriorly, the other margin becomes posterior. This whole area, this is the margin. From here, you are going to take the tissue and decide, and this is the tumor. Now, this whole is your margin. So, this is a margin assessment. Now, this will be the medial mucosal margin. This will, you can label it superior also, but ideally it is labeled as medial mucosal margin. Now, this one is lateral mucosal margin. It can be labeled as inferior also. This one is posterior. Other, you come at the bite resections. In bite resection, whole bite is taken out. This one is superior. Superior maxillary bony cut margin. This one is posterior maxillary bony cut margin. The bony cut margins are taken different separately from the soft tissue margin. So these are the mucosal margin. These are the mucosal margins. Posterior mucosal margin. This is superior mucosal margin. This one is inferior mucosal margin, and this whole area. This is tumor, so you have to take the base or the what you call it, the posterior part of the tumor, or the deep deep area of the tumor. So from this area it is going to take, and these are the bony areas. Bony areas will take uh, shave margins from there. So this is how. So a pathologist has to take lot of margins and report lot of them. This one is hemimandibulectomy. Hemimandibulectomy. So this is sarcoma of the mandible. There is not going to be much of a mucosa in this. Only bony margins are present. So this one is anterior bony margin. This one is posterior bony margins. So in larynx you have mucosal margin. Anteriorly it is epiglottis, posteriorly arytenoid area, posterior cricoid cartilage. Then there are right and left A folds of PFS for lateral edges. Then anteriorly strap muscles are present, and tracheal cartilage, you take shave margins for tracheal cartilage. Now margins can be positive, it can be close, or it can be negative. Positive margin is bad news for the patient. Positive margin patient, they recur, there is a lot of data about it. They have to give CRT, additional chemoradiotherapy after it. So positive margin is something which is we should all should avoid, and only a surgeon can avoid it. Nothing pathologist can do about it. Second thing is close margin. Close margin is a territory which is there is little bit of controversy about. If you are going to ask surgeons about what is a close margin, there's so much heterogeneity about what they think about closeness of a margin. 50% of surgeon will say margin should be more than 5 centimeters. That is not the correct way. If you and the studies around also, but the studies are so they are so heterogeneous in nature. In every organ, every site has a different margin around it. For example, 2 mm margin in the larynx is considered adequate, but 2 mm margin for a tongue, it is inadequate. For tongue, you need at least 5 mm of margin, especially if PNI is present, then the ideally it should be more than 5.5 mm microscopically. Hmm. So that is why, because of the different site, because of the article which are published for every site, they are published site wise, and all the data is retrospective in nature. All because of all those reasons make the exact cutoff around a margin a very controversial in nature. But AGCC has tried to kind of put a uh, stop to the controversy, and we all can head and neck microscopically 5 mm is good enough. In fact, if the in some of the areas, if we are around 3 mm, it is even although better too. So what is adequate margin? Is I told you, is confusion among surgeons too. So challenges, what are challenges for margin adequacy study? These are anatomic site specific. There is a controversy between primary recurrence versus secondary primary. Distance to the continuous margin is a continuous variable. It continuously changes. So what they say is by till you go till 6.5 mm, every increase in a 1 mm is going to decrease your recurrence by 15%. So these kind of it is not a something which that it is a continuous variable change. A little bit you keep on increasing margin, you keep on increasing, you keep on skimming the your chances of recurrences. Specify whether margins were revised or not. Sometimes in studies the margins were revised and these are not specified, and people take article, and there is big controversy about this also, whether revised margins are good enough or not. I will talk about it later also. In studies, margin adequate studies, they exclude cases with positive margins when determining the best cutoff between the close and negative margin. So this is a kind of a cheating which we people do in studies, and retrospective reviewing limitations of sampling. So because there is limitation of sampling, these most of the studies are retrospective in nature instead of prospective in nature. So we can do regarding margins, there are two ways to study margin. One is by you can do by the biopsy specimen. Second do is you do it intraoperatively. So what are the methods of intraoperative sampling? Intraoperative sampling can be done by, one of them is the frozen section. Now, frozen section is a very costly game, and frozen section uh, has been advocated in many centers. But the problem with the frozen section is that when you try to put data around it, it comes out to be that there is no benefit of it. Why there is no benefit? First of all, when you revise the specimen, there are studies after studies which are saying that if you tell surgeon to tell where was the previously where we have taken cut, which was the site where previously you have taken the cut. So they are unable to tell which side they have taken the cut. Second thing around this thing is why frozen section doesn't work that way, that study shows that revised margins fail to achieve any good to the patient. So if R0 has to be achieved, it has to be achieved in the first cut itself. If you are doing a second cut and then achieving R0, then we are that doesn't help, and that is why frozen section is not cost beneficial for margins in oral cancer. And microscopic spread changes the gross margin status in 5.2% frozen section helped only 2.3 patient to achieve R0, है ना? So changes the adjuvant treatment plan in 0.7% only of frozen section. So just for a 1% of the patient, we are putting frozen section, which is so difficult to. There are so much issues around it. So that is why frozen section is not cost beneficial. Second method of uh, doing intraoperative assessment is taking the tissue biopsy from the tumor bed. Now, taking tissue biopsy from the tumor bed is a game in itself, because when it was compared with the assessment of the margins from the specimen itself, it was found to be much inferior. We all agree that taking biopsies from the tumor bed data has not even been able to. My slides have been, it looks open. So there is a big flowcharts around it, how intraoperative assessment should be done. So intraoperative assessment is done by assessment of the main resection margin, starting with the intraoperative consultation. So first of all, gross examination should be done. If grossly there is nothing invisible, then directly surgeon should be called and asked that there is nothing grossly visible in entire specimen and what to gross. Then, if the grossly something is visible, then orient ink and cut into the specimen, measure distance to all the margins and report to the surgeons. If surgeon is satisfied, all margins are negative, or 5 mm positive margins are impossible to revise or close margin. So these are the conditions in which second thing is surgeon asks what is the diagnosis, depth of invasion, wants to confirm the closest margin. So we have to go according to this algorithm. This intraoperative assessment algorithm is made. So utility of frozen sections. There are three possible outcomes of margin revision. One is conversion of a positive margin into a negative one. Second is positive margin remain positive. And third is revision of indeterminate quality. Now, if you see in these three qualities, the a study was done by Amit M. et al. And in this, they told the patient to, they asked the surgeons to kindly identify which one you want to. So the mean error in identification was 9 millimeter for mucosal and 12 millimeter for deep margin. And what was the margin we want? We want only 5 mm of margin. So when mean error was 9 mm, so how come revision of the margin is going to satisfy our requirements? First of all, see, so and so because of these, frozen section is nowadays is absolutely, most of the facilities they are not asking for frozen section. Frozen section is an adjunct if it is present. If there is some controversy around diagnosis, then we can use the frozen section. Now, regarding tumor bed revisions. Tumor bed revision is a process in which when we doubt that there is any uh, s- uh, we have left the tumor, then we can send that tumor bed for the uh, review by the pathologist. Now, this tumor bed revision is also criticized because revision can be off target by about 1 centimeter in one-third of cases. Secondly, spatial relationship between positive and revised margin is discrepant. So you can never know, okay, whether you have taken the good tumor bed or not. Third thing is important to label, which is the true margin. So this lack of benefits of revision also in the tumor bed revisions too. So if you see whether it about frozen section or you see tumor bed revision, the judgment is quite clear that we have to uh, take the surgical specimen as the gold standard to decide whether we have done an adequate dissection or not for TNM staging and to decide the all the prognostic criteria. So now I'm go to what is the close margin. By itself, close margin is said when we are 1 mm to 5 mm from a uh, tumor. So close margin, some people say it is not as bad as you think because, for example, in tongue cases, if PNI is negative, if even you are 3 mm away, they will say microscopically you have not done much harm. In fact, for T1, 3 mm is good enough. So the cutoff rate between these close margin is around 2 to 3 mm. 1 mm close margin is, we all agree, it is equivalent to that it is a positive margin. So because of all these factors, intraoperative assessment is always done through the specimen itself. We have to go to the second part of the our that is TNM staging. In TNM staging, I discussed first of all that we have to first is depth of invasion. Second thing is ENE. Now, the ENE extranodal extension should be mentioned whether it is clinically present or not. If clinically present, it should be mentioned to the pathologist. Clinically, pathologist is not seeing the patient, so they won't ever know whether it was. And second thing, if it is not how clinically is known? Clinically known if two nodes are, if you see, can see on radiograph, or if it is clinically going through the skin or involving the adjacent structure or it is fixed, the lymphanodal mass is fixed. So directly, if even a single ENE is present, then the case is labeled as N3 nodes. So N3 nodes, if it is bilateral N3B and N3A. So regarding this, we all agree that so these are the factors, and now I will uh, this is from my side. I will ask Dr. Uh, Bhuvan to kindly guide through me the further part. Any questions, please? And
So,
what is the take home message? Take home away message is that the margins are the ultra important. We should not dive into the tumor and the specimen is the most important and the frozen section and other requirements around margin, other things around like revision of margin, they are not going to sort out our issues if we do the primary resection as a bad resection is done. So these are the take home away message of the this uh, class.
yeah,
Sir,
thank you, sir. Thank you so much. Now I hand over the podium to Dr. Nidhi Jadhav, ma'am, so that she can moderate the questions and what all things we as oral pathologists should know. And I should tell that sir has seen huge number of cases and he operates almost last time it was there was a case of bleeding when um uh, our session was planned, so he could not come that moment. So over to you, Nidhi ma'am.
Very good afternoon, Deepak and sir. It
Good
was
afternoon,
a
ma'am.
very nice presentation where you have briefed about the important findings which should be definitely correlated between a oncosurgeon and a pathologist. So thank you, sir, for enlightening us. Our attendees, if anybody has any question that you want to put for sir, please let sir know about it. Please let us know if any questions from anyone.
Good afternoon, sir. So this is Dr. Abhishek here.
Yes, ma'am. Good afternoon, sir.
Sir, it was a very nice presentations. I also do practice a bit of oncopath. Sir, the question from my side is like, uh, when you get the oncopath reports from different places, where do you
Mhm.
find the maximum deficiencies? Like where the pathologist should actually focus more?
Yes.
Sir,
Dr. Deepak must
if you
be.
see, they are the basic number of the lymph nodes which a pathologist should report, isn't it?
Okay,
So
sir.
AGCC say in selective neck dissection they are 10, and in the MRND modified radical neck dissection at least 15 nodes should be reported. So
Okay.
controversy arises when surgeon says that I have done all the templates of my surgery. There was no fibrofatty tissue. Because what is a selective neck dissection? Selective neck dissection is the removal of all the fibrofatty tissue between a specified templates. So once you have removed all the fibrofatty tissue in the specified template, now what remains is the job of the pathologist to report it, that how many lymph nodes were there, because surgeons cannot see exactly that there were 10 lymph node, 2 lymph nodes. They cannot see if there is any large lymph node. Berry picking is not allowed. So now that is the game of controversy. Sometimes some centers, what they do is they will send the report that 8 lymph nodes were negative. They say, okay, 8 कर तो दी और कितनी करेंगे, isn't it? So, but that AGCC criteria, they keep on changing. And latest criteria, I don't know, in ninth they might have changed it to 12 in SND.
Yeah, yeah. Yes, sir.
Isn't it? So they every time they come with a new criteria. So and in our day-to-day practice, what happens is okay, sometimes we are not able to upgrade ourselves. It can happen from the both ends, है. So that is the one of the problem which surgeons faces with the pathologist. Second thing is in the larynx. Now I told larynx 2 mm is good enough, isn't it? Sometimes they on the report they mention 2 mm, 3 mm close margin. So that thing of 5 mm in the, like, it goes off in, like everything should be 5 mm away, everything should be 5 mm away. But in the larynx, there's hardly any mucosa. We have to resuture the tube also, feeding tube also. So what we try to, we have to preserve the each and every bit of mucosa. So there is a fight between the surgeon and pathologist, what we can give to pathologist and what we have to keep for ourselves. So in that fight, they say 2 mm is good enough. So that is also some area in which there is a kind of a controversy that some people fail to recognize that you have to report it to according to the latest guidelines. Then how you cut the tissue, it is absolutely different from pathologist to pathologist. There is no specific guideline around it. Something, and you do know there is one slide I failed to. Sorry, I should have made 20 slides more. But there is one study in which the gross, it shows frozen section is good enough as good grossing. So one doesn't even know in the requirement of frozen section if grossing is good enough. So grossing is something which it is person to person. It is quite subjective, isn't it? So, and if there is a good communication between a pathologist and a surgeon, we this crossing can be done in a much better way. So these are the basic areas, sir.
So one more doubt is there. For example, there is a lateral border of tongue ulcer,
Yes, sir.
which looks very benign.
Mm-hmm.
There may be some peripheral indurations, and patient comes to actually the specialist oral pathologist, not to any other person. And
Okay, sir.
we go ahead with the biopsy, and we find
Okay,
it a very minimally invasive squamous cell carcinoma of 0.5 mm probably. And
okay, sir.
maybe the peripheral, the entire tissue may be 0.7 mm, and the
Okay,
depth of invasion may be 0.5 mm. Like
okay, sir.
hardly it is, like it is again subjective. Like few person may tell like you are getting more of a tangential cuts, few may tell it is a just a invasion, but we will give it as a micro invasive squamous cell carcinoma. Now, the question is, when we have taken the biopsy of such a small tissue with a depth, thinking it is as a severe dysplasia or something like that, to see the
Mm-hmm.
entire epithelium. But
Mm-hmm.
unknowingly, we have removed the entire primary.
Yes, sir.
Now, on the report, we give minimally invasive squamous cell carcinoma referred to a higher surgeon, and some oncosurgeons see the depression. Based on the depression, they
Mm-hmm.
go around and they chop off the tissue with some like prophylactic neck dissection. Now the
Mm-hmm.
pathologist gets the tissue and do not get any primary.
Mm-hmm.
Now it is very difficult for the pathologist to go back to the previous this thing. If they do not get the primary block again, like is there any way out, or like it is mandatory to get the
No,
primary?
actually, what in this case, ideally, what should have happened is that the revision of the block should have been done before the excision of the tumor. Any
Okay.
revision of the block, whatever has to be done. Because what we are doing is we have again operating an excisional biopsy of a minimal invasive tumor, isn't it? So, CIS tumor in this case, neck dissection was not indicated primarily.
Hmm.
What surgeon thought that how many surgeries we are going to do, he is going to do a definitive surgery. And what if that report was wrong, or what he thought that they must have wrongly assessed it minimal invasive. It must not be minimal invasive. It must be because tongue is a very high risk site. In tongue, we don't even leave the leukoplakia or pre-malignant lesions as such, because tongue and floor of mouth, they are very high risk site and they are bad disease sites. So our suspicion is always towards higher side. So he, on his good thinking process, he thought that this is a high risk side. I should treat more towards more side. So he did a selective neck dissection, thinking it to be invasive disease. In this case, if a thorough revision of the slide is again done by the same pathologist, who we are going to send the neck dissection part. If it is done, then it sorts out all the controversy. And pathologist in his part, he also can remember that, okay, it is of that case, I had done that also, and he is also part of the decision making process of the patient. So if any change has to be done, then he will also able to change it much candidly. But to expect now, after doing all this, I think it would be very tough for pathologists to change now, to go back and do all those stuff, isn't it? So that is my take. So that is why revision and review biopsies, slides, and all those stuff keep on happening in onco. It is quite a normal, I would say, practice.
Thank you, sir.
Dr. Abhishek Banerjee,
Thank you, sir.
in this regard, I would like to also say that many a times it happens कि if it's a case of early invasive carcinoma and you are confident, if you have taken deep cuts also, you have confirmed through different levels of the first block that you prepared, and if you're confident about it, there is very much a possibility, as sir told, that the second excision would be a deep wide excision. Every surgeon will not go for an intensive surgery. So that is very much possible that
Yeah,
that things might be good for the patient, and you might get negative things. Might you might not get the tumor in those slides. So basically, probably the tumor part has come out in the primary first biopsy.
No, ma'am,
Or
absolutely fine. I am just talking about that reporting part. This is fine. Like when we actually go ahead with the reporting of the second, that is the main surgical specimen, we will not get. So thing is like we have to go back to the primary block again to report the depth of invasion. Correct? Because we have to report as per the CAP protocol and AJCC. There, the mandatory norm is DOI. Now, how do we get DOI if there is no primary tumor? Because as a first person who is taking a diagnostic biopsy, he will not know that how much depth laterally or invasively it is, because he's clinically seeing an deep ulcer and he just want to see whether that is a trauma induced or whether the sometimes additional factors like tobaccos and all are very common these days, the male
it
patients and
will be
all.
TXN0. No worries, no worries, sir. It will be
Okay,
TXN0. You cannot
okay,
assess the
okay,
primary
done, done,
tumor.
done, done.
It will be TXN0, and
Okay,
nothing
okay.
can be done in these kind of things. These things are done in the good faith for the patient at the end of the day.
Thank you,
And
sir.
So, this
I
is
believe, just my take, sir. I think a good communication between pathologist and surgeon definitely can solve this issue,
it is absolute
because
paramount.
sometimes the communication part has to be done.
And
Uh,
one more, this is out of the topic, sir. Like, because you have your own circle, and like we are from this dental fraternity, and you are from the medical fraternity. Like you have, you speak to your fellow colleagues of surgical oncology, and how often you people regard oral pathologist in your group, like. Do people want oral pathologist in your surgical group, or still they prefer general pathologist with total surgical oncopath in your group? Like this is just a out of box question, may not be related to the field, this
Never
topic.
thought in that way. Whosoever is practicing, like when I was doing my residency in surgical oncology, so my colleagues were all from the dental side also. So in surgical oncology, we know that our branches, we have worked with gynecologists, we have worked with oral surgeons, we work with we have this habit of working with organ specialists, and sometimes we say that we are on a we get apartheid kind of behavior from organ specialists. If even if you go in one of the like high flying institute TMH, there are complaints from TMH also that there is a kind of a dis-synergy between organ specialist and surgical oncologist. They say we are being bad behaved. They will say we are being bad behaved. I think so. It is more of a take of a person, and these things have landed up in court also. That who can do what can do. And court have also so said that all has to live like cohabit with each other, and we should all
Yeah.
should try to respect each other. That is all. That is all. Nothing. And there are so many things which an oral surgeon know more than a surgical oncologist, because they have come from that arena also. So benign pathologist, if you ask a surgical oncologist, he's clueless about benign pathologists. But you guys are much more accustomed to the benign pathologist too. So yeah,
And
uh,
Dr. Abhishek, I just want to add that I met Dr. Deepak Nan, and when I introduced myself as oral pathologist, he was very happy. And from that day, we had nice conversations, and all these specimens, surgical oncology specimens, they are I do for sir.
No,
And
that's
one
great.
good news is there that Dr. Deepak Nan sir, he has joined POPMA also as one of
That's
the
a great. Thank you
multidisciplinary
so much,
colleagues.
sir, for joining our association.
So he is
thanks a lot,
very
sir,
pro,
for
and
accepting me.
yeah, I never find any kind of
No,
even
actually, ultimately,
simple
I think
dis.
like we should set out our ego aside, and we are doing our part of job, but we should always think what helps the patient more. So we will obviously, if we have a leg fracture, we will go to a orthopedic surgeon more than a general physician. So it's
Yeah,
just
that is
about
true.
the welfare of the patients, like even the surgical oncologist, because it's about the hierarchy, which came first. Obviously, the surgical oncology and this oncopath, it came first. So they should recognize that, yeah, the oral people, they are doing more of a oral pathology kind of. They're not embarking into our field. So kind of a specialized reporting. That's it. That is what matlab, it is a take. Anyway, thank you so much.
Absolutely.
A lot of questions to you.
There's
No
one
worries,
more,
sir.
there are
Yeah.
two more questions rather from Dr. Rahul Patil, sir. First question is, how much margin should be considered in bony tumors?
Bony tumors. In bone tumors, 8 centimeters bone sarcomas, 3 centimeter margin is good enough. 3 centimeter margin is good enough in bone tumors. And for benign pathologies, you don't need any margin. For sarcomas, 3 centimeters. Yes, yes.
There's one more question from sir. Is lymph node ratio beneficial to you?
Lymph node. Now, this was a interesting story regarding lymph node dissection. It was a story was started by TMH. TMH Mumbai showed that if you do a prophylactic lymph node dissection, uh, then the you save as many as 12% patient more, 71% versus 59%. So 12% more patients are saved if you do prophylactic lymph node dissection in a patient of, like, if you have done or not done a for example, it is an oral cancer, you have not done prophylactic lymph node dissection, you follow it thoroughly. Moment any lymph node comes, you do a neck dissection at and there and then. Even in that subgroup of patient, the 5-year-old survival dips down to 59%. So prophylactic lymph node dissection has to be done even if it is N0. You stop the seeding, you stop the micrometastasis, you stop the tumor biology from spreading out. Whenever a tumor changes its type from T1N0 to T1N1, we change the stage of the patient. It goes to a stage 3 directly. And nodal staging is one of the after the margin, nodal staging is one of the most important risk factor in the oral cancers. So yes, we have to primarily stage it. We should not only in tongue cancers when tumor, we are sure about MRI, we are sure that the tumor has not invaded beyond 3 mm. Only in that subset you can leave lymph node dissection. Otherwise, lymph node dissection has to be done. And these results now has been validated in Britain, China. Every center is now saying the same data which was shown to us by TMH, that has been with their CT scans, with their kind of radiology. We have been able to replicate the data. They have been able to replicate our data. So yes, 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 always.
Sir, I have one question regarding sentinel lymph node, what is resected in few tumors. Sir, so according to your clinical experience, what?
Sentinel lymph node is good, no worries. Everything is good about it. The thing is that it takes time.
Okay,
It
so
takes
the
time, it takes money. So even in United States, it is not being done. That is two things. Sentinel lymph node has a good concordance rate in head and neck cancers. So do sentinel lymph node and do everything. But what happens, you will send the node for the frozen section. You will wait for 15, 20, 30 minutes. By that time, that dissection will be complete, isn't it? So that is why in head and neck cancer, no head and neck surgeons are they are not too much interested in sentinel to go ahead like the way it is being done in endometrial cancer or other cervical cancers or other areas. Reason being because of these two, like one time, second thing is money.
So if we go by the routine protocol, not the frozen section one,
Uh,
does that really help in the long term prognosis wise? Matlab, how is your experience about the cases if in case you have?
Frankly speaking, I haven't worked, but the data, what data says, yeah, it works. Frozen in head and neck cancer, sentinel lymph node dissection can be done. It has a nice concordance rate. It has 2% FNR, false negative rate, is only 2%. So there is not much of a worry. We can go ahead with it, but thing is that uh, since I haven't worked over it in Delhi, there is no center which is right now going ahead with sentinel lymph node dissection. And in Hisar also, we are not doing it. So, yeah, in breast and all, the what happens is the lymphedema created by lymph node dissection is so much that there is a call for a do lymph node, kindly do SND, kindly. In head and neck cancer, there is no the morbidity associated with neck dissection is not so much, especially with modified radical neck dissection, especially with selective lymph nodal dissection. The morbidity is not so much. So there is not call from the patient side also that whether we should do go ahead with it or not. But yes, it can be done. It is feasible. It is feasible.
Okay. So there's one more question from Dr. Abhishek Banerjee. What is advised in follow-up visits? Any investigations as the PET scan is costly?
For pre-operative workup, PET scans you are asking. Ma'am, for
No,
large tumor
follow
T3,
up,
T4 tumor,
follow up. Sir,
So,
follow up.
follow-up,
yes,
follow-up.
it is follow
Ma'am,
because every time doing the PET scan comes out to be expensive. So, is there anything else
Yes.
that we can
no PET scan as such is
keep in
not
advance?
advised that one should go ahead with. The clinical examination is good enough. Along with it, your
Very.
normal investigations, like if we are suspecting uh, something ahead with the chest, then go first ahead with the chest X-ray. If it is a pleural effusion, then why even a PET scan is required? So the case of head and neck cancer is supposed to fail in chest first. And if it fails beyond clavicle, it is failed case. Nothing much we can do ahead with. Now recurrence can be checked clinically very nicely. And then there, if you suspect anything, CTs and MRI work very good. So for follow-up, PET scans are only required for those kind of tumors in which we are not able to sample it pathologically, like for base of tongue tumors in which radiation has been
Yes.
given. So for that follow-up, PET scan is required. For simple tongue, PET scan is done much more because the patient insists. Patient will keep, he will say, Doctor लिख दो ना PET scan, मेरी चिंता दूर हो जाएगी. Because of these kind of things, not any other reason. It is not indicated as such so much. If you will go in indication, you will keep on searching for the indication. There's no indication.
Uh,
So there is a comment. I mean, Dr. Shipra Deshpande has praised you. Thank you very much, sir. It was a very informative session.
Thanks a lot, ma'am.
uh, Ma'am, I think vote of thanks and felicitation for sir.
On behalf of POPMA, that is Practicing Oral Pathologist and Microbiologist Association, sir, we are very, very thankful to you for joining us today as a speaker, enlightening us about this topic, which is always there is a loophole between surgeons and pathologists. That connection, as you told, should always be there thoroughly. So we thank you, sir, for enlightening us. It was a nice session, and I'm
Thanks a
honored
lot,
to
ma'am. Thanks a lot, sir.
present this certificate to you, sir. Thank you so
Thank you.
much.
Thanks a lot, ma'am, for letting me speak here. Thank you, ma'am.
And I request everyone to put on their cameras. We can have a photograph, a group photograph.